Neuroleptic malignant syndrome is an uncommon but possibly fatal reaction to certain medications used to address mental health problems. The term NMS refers to a collection of symptoms that impact the nervous system, muscular system, and other bodily systems. Fever, muscular stiffness, disorientation, changes in heart rate and blood pressure, and other potentially severe consequences are possible. NMS can be triggered by a variety of drugs, including both traditional antipsychotics like haloperidol and chlorpromazine, and atypical antipsychotics like olanzapine and risperidone. Antidepressants and antianemics are two other medications that have been linked to NMS. NMS symptoms usually appear within a few days to a few weeks of beginning or raising the dosage of the offending drug. The symptoms can be serious and necessitate prompt medical care. Stopping the drug that can cause the response, providing supportive care such as hydration and cooling measures, and delivering medications to manage symptoms are all possible treatments. Kidney injury, respiratory failure, and cardiac death are all possible complications of NMS. NMS can be fatal in rare instances, especially if not identified and handled quickly. Nursing care for patients with NMS involves constant tracking of vital signs, hydration state, and mental status. It is essential to identify the indications and symptoms of NMS early, as prompt therapy can better outcomes. Nursing care should be focused on keeping the patient's safety and comfort, giving information about the disease and its treatment, and working with other members of the healthcare team to provide complete care.
Extrapyramidal side effects, or EPS, is commonly referred to as drug-induced movement disorders that are among the most common adverse drug effects that patients experience from dopamine receptor blocking agents. EPS describes involuntary movements that you cannot control. These effects are most common when taking antipsychotic medication. Some symptoms of EPS include the inability to sit still, involuntary muscle contraction, tremors, stiff muscles, and involuntary facial movements. EPS usually occurs in patients taking class 1 or first generation antipsychotic drugs. This is due to the drugs being developed during a time when medicine was not as advanced as it is today. EPS has specific side effects. 4 of these effects include akathisia, dystonia, Parkinsonism, and tardive dyskinesia. Now, akathisia is when you're feeling restless, like you can't sit still, or you may have the urge to tap your fingers, fidget, or even jiggle your legs. Dystonia is when your muscles contract involuntarily, and in some patients this can be painful. Parkinsonism. The symptoms are similar to Parkinson's disease, so you may have a tremor, difficulty finishing thoughts or speaking, and stiff facial muscles. But while a loss of nerve cells causes Parkinson's disease, this medication causes Parkinsonism. Tardive dyskinesia is when the facial movements happen involuntarily. You may be sucking or chewing motion. You may make a sucking or chewing motion with your mouth, stick out your tongue, or blink your eyes a lot. Now, complications. Antipsychotic induced metoclopramide induced laryngeal dystonia has been reported predominantly in young males. Rhabdomyolysis is another complication, and it is rare of drug-induced dystonia, especially if prolonged dystonia is present. While dystonic storm typically occurs in patients with primary known dystonia, triggers typically include infection and medication adjustment in significant number of cases. A dystonic storm is a life-threatening situation that manifests with fever, tachycardia, tachypnea, hypertensive crisis, diaphoresis, dysphagia, and respiratory failure. The manifestation of EPS in schizophrenic patients is associated with poor compliance with other atypical antipsychotic medications, which may subsequently lead to relapse of schizophrenia or hospitalization. Failure to correctly diagnose and treat EPS is linked to suicidal ideation, aggression, and violence. Nursing management of EPS would be to perform an AIMS test, AIMS, with conventional antipsychotics, monitor for signs of dry mouth, sedation, and blurred vision. You should always also monitor vital signs.
A patient by the name of John Zane, age 43, got admitted to the psychiatric ward after being brought to Sonderlands accompanied by a close relative on March 17, 2023. Mr. Zane is now a known schizophrenia patient being treated with cognitive behavioral therapy and medication. That's tab olanzapine 20 milligrams and tab haloperidol 5 milligrams. Mr. Zane had reported to his doctor that after 2 weeks, the haloperidol had given him mouth ulcers, chest pain, and breathlessness. The patient also explained that he experienced paranoid spells, believing that his ex-girlfriend had taken his hair and done black magic, and his child is an alien sent to kill him. He also experienced sleeplessness, aggressive behavior, muttering to self, abnormal movement of lips, head and neck contractions, and change in posture from pain. The patient was admitted for monitoring. In the meantime, had been prescribed tramadol for the pain.
My care plan under assessment, my need would be self-actualization, where the patient would learn and understand how to communicate with others. For my findings, there is no subjective data, and for my objective data, the patient has difficulty speaking. For my diagnosis, it would be impaired verbal communication related to dysarthria as evidenced by impaired speech. For my goals, at the end of an 8-hour shift, the patient will be able to use effective communication techniques. For my interventions, I will assess the conditions that affect speech, where I will help to identify any impairments such as autism, which affect the patient's ability to verbally speak. I would evaluate mental status, which would identify any psychological conditions that disrupt the patient's speech. I would use aids and devices, which would help with speech impairment. I would use sign languages, which would help communication, and I would use an interpreter, which would help with communication. With my implementation, the patient was assessed for conditions that affect speech, which would help to identify an impairment. The patient's mental status was evaluated to identify any psychological conditions that disrupt the patient's speech. Aids and devices were used to help with speech impairment, and sign languages were used to help with communication. An interpreter was also used to help with the patient's communication. Under my evaluation, the goal was partially met, as evidenced by patients being able to use effective communication techniques. With my 5 diagnosis, my first priority diagnosis was impaired verbal communication related to dysarthria, and the second one would be hypothermia, which is related to infection. The third would be impaired physical mobility related to muscle stiffness. The fourth would be decreased cardiac output, and the fifth would be ineffective breathing patterns related to dyspnea. And for any additional nursing care provided, I would use speech therapy, which would help with better communication.
A patient by the name of Jane Pickle, age 61, got admitted to the psychiatric ward in a confused state with impaired speech and no psychiatric symptoms. Mrs. Jane Pickle was said to be a schizo patient of 27 years, and her condition is stabilized. Despite her stabilization, Mrs. Jane Pickle's husband explained she had been experiencing symptoms of confusion, agitation, muscle rigidity, and dysarthria. The patient had been taking haloperidol 100 milligrams teapot administered once every 3 weeks by her nurse. After the investigation, doctors had diagnosed Mrs. Jane Pickle with neuroleptic malignancy syndrome and are closely monitoring to find the underlying cause. Her new diagnosis is haloperidol 5 milligrams 2 times a day and lorazepam 1 milligram 2 times a day for agitation as well as speech therapy. This care plan for neuroleptic malignancy syndrome covers the Maslow's hierarchy category of safety and security. The patient objective data is facial grimace displaying pain in the neck. The nursing diagnosis is acute pain related to muscle contractions in the neck as evidenced by stiff neck and abnormal posture. The goal for the patient is over the 8-hour shift to display relief of pain. The interventions throughout the 8 hours consist of assessing the patient on a scale of 1 to 10 to acknowledge how intense the pain is for proper treatment, providing non-pharmacologic pain treatment such as massages, heat and cold applications to relieve pain instantly by reducing tension in the muscles, to instruct immobilization in order to restrict movement with splints or supportive devices that can release the pressure, administer non-opioids because they are effective in managing mild to moderate pain, and administering opioids as prescribed by the doctor for severe pain. The implementation is as follows. Ask the client their pain levels on a scale of 1 to 10. Document findings. Massage the affected area in circular motion. Apply an icy hot muscle cream. Apply warm or cold rags. Apply splint or brace to the neck, restricting movement. Administer NSAIDs such as ibuprofen or Tylenol. Administer tramadol for moderate pain as prescribed or morphine for severe pain as prescribed by doctor. The goal at the end of the 8-hour shift was met. Patient verbalized a relief of pain. Pain scale from 8 to 4.